Well, hello everyone. My name is Vivian Ip and currently the chair of the Regional Anesthesia Section at CAS. I'm delighted to collaborate with ESRA to celebrate the second World Day of Regional Anesthesia, and I'd like to welcome you all to our webinar. Without further ado, I'll hand over to Joanna Fifen, who is the moderator of our webinar today. Joanna.
Hi there, can everyone hear me? Welcome everyone. I will be your moderator today. I'm a staff anesthesiologist and site research lead at the University of at the South Health campus in Calgary, and I'm a clinical assistant professor in the Cummings School of Medicine at the University of Calgary. Just an acknowledgement slide here. Many of us are joining today's meeting from lands across North America, which is known as Turtle Island by many Indigenous communities, and I am currently situated in Calgary. We appreciate and acknowledge that we live, work, and play on the ancestral and traditional territories of the Blackfoot Confederacy, made up of the Siksika, Piikani, Skapiikani, and Gaina First Nations, the Athika, Nakota, Wekatsabi First Nations, comprised of the Chiniki, Bearspaw, and Goodstoney First Nations, and the Tsuut'ina First Nation. The city of Calgary is also homeland to the historic Northwest Métis and to the Otipemisiwak Métis government, the Métis Nation Battle River Territory, Nose Hill Métis District 5, and Elbow Métis District 6. We acknowledge all Indigenous peoples who have made Calgary their home, and I'd like to encourage each of us to continue our journey to learn about the history and ongoing stories of Indigenous peoples where we live and work. We have an amazing group of presenters today, and I'll introduce them and then they'll get started on their presentations. So first we will start with Dr. Vishal Uppal. He will be speaking to us about rebound pain. He is an associate professor at Dalhousie University in Halifax, Canada, and he is a board member of ESRA Pain Medicine. He is also the scientific program committee chair for the 2025 ESRA spring meeting, and formerly he served as the chair of the Regional Anesthesia and Acute Pain section of the Canadian Anesthesia Society. In recognition of his exceptional scientific contributions, Dr. Uppal was awarded the prestigious 2024 Presidential Scholar Award by the American Society of Regional Anesthesia and Pain Medicine. He has authored over 70 peer-reviewed papers and book chapters, and is the lead author of the recent multi-society guidelines on post-dural puncture headaches. Dr. Uppal also serves as an associate editor for both the CGA and RAPM journals, and his clinical expertise spans regional anesthesia, acute pain, obstetric anesthesia, and evidence synthesis. Our second presenter is Dr. Peter Rose, and he will be speaking about nerve injury and its management post-regional anesthetic. Dr. Rose is a staff anesthesiologist at Vancouver General Hospital, and he completed his anesthesia residency training at UBC and a fellowship in regional anesthesia and acute pain at the University of Ottawa. He works at Vancouver General Hospital, where he is a co-director of the perioperative pain service and leads the airway and major head and neck surgery anesthesia division. He's also a member of the regional anesthesia division and has a particular interest in teaching and continue learning about regional anesthesia and airway management. Our third and fourth presenters are Dr. Ashtem Niazi and Dr. Riva Ramlogan, and they will be speaking about how best to teach regional anesthesia to the next generation of students. Dr. Niazi finished his medical education in Pakistan and completed his training in anesthesia in the Republic of Ireland, where he did a fellowship in liver transplant surgery in Dublin, Ireland, and a fellowship in regional anesthesia and acute pain in Toronto, Canada. He is currently a staff anesthesiologist at Sunnybrook Health Sciences Centre and an associate professor at the Department of Anesthesia and Pain Medicine at the University of Toronto. He is currently the Vice Chair of Education and a clinical educator at the University of Toronto. Dr. Ramlogan is an associate professor and fellowship director at the University of Ottawa. He is also the prior chair and current vice chair of the Educators in Regional Anesthesia Special Interest Group at ESRA. Our fifth and sixth presenters are Dr. Vivian Ip and Dr. Ryan Endersby, and they will be speaking about emerging techniques in regional anesthesia and acute pain. Dr. Ip is a clinical professor at the University of Calgary in Alberta, and she's a practicing anesthesiologist with fellowship training in regional anesthesia and pain medicine, as well as ambulatory anesthesia. At the South Health Campus in Calgary, she is the director of the Regional Anesthesia and Acute Pain Medicine Fellowship Program. And with the CAS, she is the chair of the Regional Anesthesia Section and the chair of the Environmental Sustainability Section. She also works to do the ESRA Pain Medicine. She's the chair of the newsletter committee and chair of the Green Anesthesia Special Interest Group. And along with these roles, she also serves as editor for the Journal of Regional Anesthesia and Pain Medicine and a member of the editorial board of the Canadian Journal of Anesthesia. She is active in research and continues to publish at peer-reviewed journals. Dr. Andersby is a staff anesthesiologist and director of the acute pain and cryoneurolysis at the South Health Campus in Calgary and an assistant clinical professor with the University of Calgary. He is extensively involved in pain medicine and ultrasound-guided regional anesthesia and perioperative ultrasound education for staff, residents, and allied health professionals at the University of Calgary. He is also the University of Calgary Regional Anesthesia and Acute Pain Medicine Fellowship Co-Supervisor and the Perioperative Ultrasound Fellowship Site Supervisor at the South Health Campus. He is actively involved in the Alberta Pain Strategy. He is very interested in regional anesthesia and pain medicine research and perioperative ultrasound and has published several peer-reviewed publications related to these topics. He is also interested in cryoneurolysis and cryoanalgesia for acute, transitional, and chronic pain, as well as in the treatment of spasticity. He has undertaken a number of advanced training programs related to these techniques and hopes to advance this new area of anesthesia through his clinical work and research. So we will end the 90-minute session with questions. So please save your questions until the end and let us begin.
Let me just share my screen. Perfect. Looks like you should be able to see my screen now. Joanna, can you? Perfect. Thanks. Thanks for the detailed introduction. That was a handful of introduction. Thank you so much. And it's a pleasure to be here for the World Day of Anesthesia. And thanks CAS as well. Next 15 minutes or so, I'll be talking about rebound pain, mainly prevention and treatment strategies. Okay. This is my disclosure slide. I have no financial ties with companies manufacturing ropivacaine, although my Twitter handle is ropivacaine. The next question is, why me? This is one of the papers we published from DAL. Was arguably one of the most influential paper on rebound pain. I'll talk about this paper later on, but that's the reason I think I'm talking here. Defining rebound pain. There are about, I would say 8 to 10 definitions of rebound pain. Luckily for me, there's a paper in German which published all these in one place, so that I didn't have to do all the work. And even more luckily, they had translated this into English for me as well. So I've highlighted a couple of them. Basically, the first one talks about it's a mechanical or surgical pain, which is unmasked when the block wears off. And the second one, which I have highlighted, is the one which talks about going from a controlled pain when the block is working to uncontrolled pain when the block wears off. What it is not is state of hyperalgesia, which some of the basic sciences literature suggested. There is very little clinical evidence to suggest that is the case. Making it simplified, I think is the easiest way to understand rebound pain is to think about surgery as marriage. The pain is coming. What the block does, it provides you with a honeymoon period where there is no pain, there is no nausea and vomiting, and you go home quickly without any of these side effects. And then once the block wears off, life is back to normal. So it is a problem. Almost 50% of our patients who get block actually suffer from rebound pain, which means that they have good control of pain. They have no nausea and vomiting, and then suddenly their pain gets uncontrollable. They end up in hospital, needing more medications, might have financial costs as well. So what can we do to prevent it? The first thing we have to do is to identify the factors so that we can select or find the patients who are at higher risk of rebound pain. And this is for a plot from our own paper, which suggested that younger age, female sex, and bony surgery are higher risk for rebound pain, as well as the absence of dexamethasone during the perioperative period. It's also good to know which is the most important factor, and having bony surgery is probably the most important factor, and which doesn't come as a surprise to most of us. So what are the possible options we can use to prevent or treat rebound pain? Here's a list which I thought about. First of all, identify the patients, which we already talked about. We can use aggressive multimodal analgesia. We can use adjuvants like long-acting drugs or perineural or IV adjuvants like dexamethasone, or we can attempt to prolong the block duration by using continuous peripheral nerve blocks, or we can time opioids to when the blocks are wearing off so that the effect of rebound pain is blunted. Let's talk about the evidence behind these interventions. There are a few review articles published, but it's a very rapidly evolving field. The most recent one is the one which was authored by me in ASRA Monitor, ASA Monitor, sorry, which is on the right side of your screen here. So let's go over some of these factors one by one. The most studied factor is dexamethasone. And there was a systematic review published in BJA last year, which looked at this intervention. And by using dexamethasone, the risk of rebound pain was reduced by almost 85%, which gives us a number needed to treat of 2.9. They also looked at the duration when the rebound pain occurs. It's about 8 to 10 hours is what they found that rebound pain was happening in most of the patients. What about comparing IV with perineural? So let's just go over the IV dexamethasone. And there are quite a few studies. The green tick box means that these studies indicated that the intervention was helpful. Later on, I will show you crosses, which means that it was not helpful. As you can see, consistently, dexamethasone IV was helpful in almost all the surgery. I just put a question mark in the last study here, because this was a study comparing high dose versus low dose dexamethasone, and they did not find a difference between high dose or low dose. But I have to point out that the sample size was probably not enough, and also it was observational studies. But from previous literature, we do know that dose of dexamethasone has to be close to 0.1 or more than that per kilogram for it to be having any analgesic effect. Below that dose, you might have some antiemetic effect, but you'll probably not get analgesic effect. What about perineural dexamethasone? A few studies, the one which used a lower dose did not show a positive results, but all others did show positive results. So IV or perineural, both are effective. And actually, there was one study which compared IV and perineural directly as well. And what the study found was a bit strange, because it said that perineural was not helpful, but IV was, which is a strange finding, because eventually perineural will get absorbed systemically as well. So I think if someone's looking to do a trial, maybe this is some trial which they should be doing to see if this is true or not. Right. What about the other adjuvants? I'm really not a big fan of mixing in professional or personal life, but we'll talk about some of the other ones. Dexmedetomidine is the one which we talk about quite a bit. And the study looking at rebound pain with dexmedetomidine showed that it was effective, almost as effective as dexamethasone, but it does come with the side effects like bradycardia and sedation. So on head-to-head, I think dexamethasone wins in this regard. What about ketamine? The graph on the right, the top one, shows perineural versus IV or placebo. And you can see the perineural was effective, but IV ketamine was not effective. But I have to stress that the perineural use of ketamine is off-label use. So I'm not a big advocate of using ketamine perineurally. So far we have discussed dexmedetomidine, we've talked about dexamethasone, we've talked about ketamine. Other things are like long-acting local anesthetics, which is actually not available, liposomal bupivacaine in Canada. But the studies are not yet promising, but this is some space to watch for. We also talked this study looking at remifentanil and reducing rebound pain, not found to be effective. And finally, also found one study which is looking at transauricular vagal nerve stimulation, and it did actually found that it was effective. In other words, distraction therapy is maybe helpful. Coming to opioids, we can give opioids IV, we can give them subcutaneously or orally. If they're in hospital, obviously you can give them subcutaneously or IV. The problem happens if they're gone home, in which case the oral is the only option left. So our own data showed that we were trying to do is looking at rebound pain, giving a dose of hydromorph 6 hours after interscalene block, and we actually found that it was not effective. But we probably mistimed it because at that time, 6 hours was thought to be the time when rebound pain occurred, but now we know it's more like 8 to 10 hours the pain will occur. So we probably mistimed it. So another area to watch for in future research. Last few slides, we talk about continuous peripheral nerve blocks, and you can see there are some red crosses and some green tick boxes on the right side there, which means that the results are mixed. And the reason for that is because you can see that the duration of continuous block was different in all these studies, as well as the type of surgeries was different. I'm just going to pick one of those studies to show you what happens there, or this is a graph from one of the studies. The black line down there shows a single shot block. You can see that the pain is drastically less initially and then gradually rebound occurs. The top dotted line shows the placebo group or no block group, which again shows that high pain scores initially and then eventually all the three graphs merge. The middle one is the one which I'm talking about, is the continuous peripheral nerve blocks. Normally, we would have expected continuous peripheral nerve block to work as if a single short nerve block initially, and then prolong the effect of analgesia, something like this. But in reality, it doesn't happen, maybe because it is a technique which requires more skill, and it's also maybe inherent failure of the technique as well. Yeah, what all I can say is that evidence is not convincing for peripheral nerve blocks, but if they work well, actually, that's probably a good way to control rebound pain. So in summary, this is my approach, and feel free to pick and choose what you want to do. I identify patients early on to see who will be at high risk of rebound pain. All patients receive aggressive multimodal analgesia. We see so many times that our patients don't like taking medications if they don't have pain. So education plays a very important part here. Patients have to be educated that the block will wear off and the pain will come pretty severe. So have your painkillers before your block wears off. We repeatedly keep doing that. Still, we get a lot of patients who don't because that's the nature of things. Dexamethasone evidence is pointing towards that it is really helpful to reduce rebound pain. So if a patient is getting a GA, usually we give a dose of dexamethasone. I would say is give a decent dose, at least more than 0.1 milligrams per kilogram. If they're getting sedation, then also give them some dexamethasone and make sure you give it slow. and give it after sedation, because in awake patients, actually, dexamethasone can cause flushing and perianal itching sensation, which can be quite distressing. Blocks, opioids, you can ask them to take opioids when the block is wearing off. Again, people don't like doing that. And finally, for the patients who are highest risk of having rebound pain, I think using a perineural catheter is a great approach. And if your resources permit. This is one of my last slide, because I do get some surgeons who come to me saying that don't do blocks for my patients because they will get rebound pain. To them, I actually go and tell them about the marriage scenario. If you were getting married, would you forego your honeymoon for the fear of what is coming later on? They usually do get convinced about having patients getting in the block. Finally, I would like to end up with these couple of slides. We're having the 50th annual ESRA spring meeting in May in Orlando. As a program chair, I would like to invite you, and I can promise you a good mix of education and entertainment. I'd also like you to invite you to Newfoundland in June. The abstract submission deadline is tomorrow, so you don't have too much time. Please go ahead, and we look forward to seeing you at both these meetings. Thank you. To stop sharing my screen.
Okay, can everyone see me there? Can you hear me? Great. Well, Dr. Uppel is a very tough act to follow. And thank you, Joanna, for the very nice introductions before. So my name is Peter Rose. I'm an anesthesiologist at Vancouver General Hospital, which is in Vancouver, British Columbia, on the very far west coast of Canada. And I'm going to be talking about peripheral nerve injuries today in relation to regional anesthesia. So first of all, I have no disclosures or conflicts to describe, and you know, my objectives here for the short presentation are, first of all, to understand the prevalence of peripheral nerve injury in the perioperative period, and describe the pathophysiology briefly and etiology of peripheral nerve injuries associated with regional anesthesia, and then explain appropriate assessment, investigations, and management of these injuries in the context of the perioperative period and relating to regional anesthesia. And I think, you know, this is a topic that's not only important for anesthesiologists, but very emotional. You know, as physicians, we're always trying to do the best thing for our patients and really avoid harm. And when it can be seen as something as a direct result of a procedure we might be doing, such as a nerve block, it's quite distressing. So, you know, when we're talking about nerve injury in the context of a regional anesthetic, it has to be taken in the whole perioperative picture. But again, similar to rebound pain that Dr. Uppel was mentioning, it's kind of tricky to define. But really, what we're looking at is either a patient-reported or a practitioner noticed or assessed decrement in neurologic function following a nerve block procedure or in the perioperative period. When we look at a large pool, this is data from a few years ago, but looking at over 350,000 patients who had surgery of all kinds and anesthetics of all kinds, the overall risk was about 3 in 10,000 of peripheral nerve injury. And interestingly, this had no association with whether a peripheral nerve block was provided or not. So interesting food for thought, and this continues with subsequent studies. When we're looking at the risk of injury from a peripheral nerve block itself, we have some sort of robust data that's continued to be consistent with these numbers. At about the 3-month period, we're looking at a rate up to 2.2%, 6 months, 0.8%, and after a year, as low as 0.2%. And when we're looking at actual permanent nerve injury, we're looking at rates in the range of 0.014, 0.04%. So about 1 in 10,000 risk of permanent nerve injury. And what we can see here with this data on our right is that it really depends on the type of surgery that we're looking at. Now, to have a good understanding of the concerns of nerve injury, we have to have a basic understanding of the neuroanatomy. So this is a depiction of a peripheral nerve here. On the outside, we see the epineurium, which seemingly is the tough outer covering, but really it's quite a permeable and compliant structure that doesn't necessarily provide a lot of protection, but more keeps the fascicles, which are the key piece to the nerve, surrounded. Our primary piece of the structure is our fascicles, and they're surrounded by a perineurium, which is actually our robust chemical and mechanical barrier that actually, in a sense, acts as a bit of a blood-brain barrier for the nerve, and is where the real protection is provided. And when we talk about vascular injuries, it's important to recognize that there's sort of two components to our vascular supply or vasa nervorum, extrinsic and intrinsic, extrinsic being in the infracranial epineurium, and intrinsic being in the endoneurium. Both are at potential risk of concern. As far as the pathophysiology goes, this is important when we look at the symptoms we see and the investigations we see. So, on the reassuring side of things, most injuries that occur in relation to regional anesthesia are mild, and we have two scales here. We have the Seddon scale, which refers to neuropraxia, typically with paresthesias. This is our most mild form of injury, typically with focal demyelination, resulting in some evidence of slow conduction on electrophysiology studies. More severe would be axonotomesis, where there's axonal injury with varying degree of injury to the other connective tissues in the nerve, and then neurotomesis, which is a complete severing of the nerve and would be severe. And the outcomes are correspondingly elevating degrees of severity. There's the Sunderland scale, which breaks down a little bit further, as you can see in this table here. But really, neuropraxia is our most mild form of injury, typically related to stretch or compression, and very reassuring prognosis, where neurotomesis is our most severe form of injury and our most concerning. When we think of the etiologies of the injury, really, they're into four main categories, being mechanical, related to pressure, which actually go together with our needle passage and injection pressure, and then chemical, whether that's due to the neurotoxicity of local anesthetic itself or adjuncts like epinephrine, for example. And then similarly, vascular injury, whether that's related to hematoma and in the, say, the anticoagulated patient, or vascular compromise due to trauma or vasoconstriction. So, with that said, these all go together and present a multifactorial picture. When we're the one providing the regional anesthetic, we think of what we see here in the image. So we see an intraneural and then intrafascicular injection, which is probably where most of our mechanical nerve injuries happen, or nerve injuries associated with regional anesthesia occur. And that's compounded by the pressure that occurs with injection in an intrafascicular type injection. We also think of our familiar ESRA guidelines for coags, adjuncts like epinephrine. But the picture gets a lot more muddy when we look at the broader picture in the perioperative period. So we have our anesthetic concerns, but we also have surgical concerns, whether they're traction, trocar placement, instrumentation, cast application, as we can see here, and then patient factors. So peripheral neuropathy, pre-existing neuropathy, whether it's related to diabetes or many other pathologies, is a big concern. So we really have to take the injury and look at the whole patient and the whole scenario before getting and moving further. And this study by the group out of Toronto Western was just from a few years ago, and it's a large study of over 19,000 patients. It was retrospective, but what they did was define the etiology of the different patients with peripheral nerve symptoms and peripheral nerve injuries. And what is consistent with the older data is that of these, there were 20 patients that reported injuries lasting more than 10 days, and 3 of these were found to be related to the nerve block itself. So 15% of these injuries were nerve block related, and the remainder were either surgical, could not be determined, or were from non-surgical or nerve block concerns. So this is consistent with that multifactorial etiology typically. When it comes to assessment of the patient, this is probably where our intervention and assessment is most important. So really, above anything else we can do, when there's been an injury, early recognition and access to the patient is the key piece. So there are a number of barriers that have been defined that can obscure our assessment of the patient. This can be things like sedation, ongoing sedation, the post-operative period. It could be a post-op analgesics like opioids. And then the regional anesthetic itself can blur things. And as Dr. Uppel was mentioning, with adjuncts and with catheters, there may be a prolonged nerve block, and that can obscure the assessment. And in addition to that, a lot more surgeries are happening in an ambulatory setting now, where patients are having their procedure, the nerve block is still in effect when they go home. So there needs to be a robust way to follow these patients. Otherwise, they can be missed and go for days without being assessed. So I think the key piece is that there's assurance of having a reliable system of assessing the patient, whether this is an in-person assessment for an inpatient, a telephone call, or a return to clinic visit of some sort. And in addition to that, the importance of having patients be informed prior to the procedure what to look out for, what to expect, and have a true sense of what to be concerned of after the procedure. So as far as assessment and management goes, luckily, there are a number of guidelines and statements that have been put out. 2015, ESRA put out their second review of perioperative management of nerve injury. And RAUK provided a similar guideline, and this was revisited again in 2021 with the RAUK document that we can see here. So I've decided to go through this in the sense of a patient that may be worked up for peripheral nerve injury. So as we described, it's very important to follow these patients in some form with interactive follow-up. It should be done within the first 48 hours. And really the first question is there neurologic dysfunction suspected, or is this a concern? So if it's not, continue on the typical pathway, make sure they have multimodal analgesia. And if there is, the next goal is to review their history, pre-existing neurologic deficits, and carry on from there. And then our next question becomes, if there is a deficit, are there any pre-existing deficits? And of course, if there are pre-existing deficits, this is reassuring. But if there are, document those and move on. So if there are deficits, a couple of questions can help determine what the next steps are. First of all, is this a lack of resolution of the block due to either a prolonged block, catheter, or are these new onset symptoms, whether this be pain, paresthesias, or weakness? And depending on what the findings are, this is now time to involve the surgical team, the anesthesia team that was involved with the patient, and have a frank discussion about what the concerns were potentially related to the surgery, related to the block, get a good sense of what was done during the procedure, and review the patient's medical history. And then comes the most important question, raising alarm bells or not. So is motor function affected, and are the symptoms progressive, and or is the deficit painful? These are our red flags resulting in an urgent discussion, urgent management of the patient. So if we go down the pathway of the urgent lesion, this is what it looks like. So questions would be, is this likely concern related to the nerve block itself? Things we'd consider to be hematoma, compression of the nerve, or is it likely a surgical related issue, whether it's compartment syndrome, hardware, bone fragments, or hematoma? Regardless of the issue, it's important to involve senior neurology consultation to expedite any investigations. as well as surgical involvement. The more time with a compressed nerve, the higher the risk of ongoing injury. So there needs to be emergent assessment for potential surgical compression and anything that can be done to definitively manage this. So if we're going down the path of urgent lesion, imaging is a key piece. The things we want to rule out would be hematoma, whether this is a gross hematoma, microhematoma around the nerve, compartment syndrome, or a hardware causing issue. Our imaging modalities would be MRI, of course not as available as ultrasound, and interestingly less sensitive with respect to nerve injury than ultrasound. Of course, for deeper structures or structures that are obscured by bone, much harder to access. But ultrasound, much easier to access with MRI, but ultrasound is something that should be accessible to everyone and certainly can play a large role in guiding management, whether it be surgical or otherwise. And regardless of the management, whether it's surgical decompression, repair of the nerve, there still needs to be involvement of the acute or chronic pain team, as well as physical therapy or occupational therapy to prevent subsequent injuries, whether they're related to contractures or pressure injuries. I wanted to take a moment to talk about ultrasound and the importance of this in assessing nerve injury. This is a bit of an evolving technology in this regard. Typically, we think of imaging such as MRI or nerve conduction studies or EMG that we'll talk about in a moment. But there's actually a huge amount that can be done with ultrasound. As I mentioned, the sensitivity is quite high and higher than MRI. And in a number of cases, actually, compared to our neurophysiologic studies, is able to guide treatment. And in a sort of comparison, there was actually 50% of the patients that were reviewed with both actually had their treatment changed by ultrasound review. What we can typically see is swelling of the nerve, as we can see here in the median nerve. And it's subtle, but certainly there's nomograms for normal nerve caliber that can be assessed and very easy to do at the bedside. Similarly, we see an example of a traumatized sciatic nerve with some edema and significant change in its ultrasonographic image. And similarly, a sciatic nerve here with some compression, and then a median nerve here that has had full transection. Other things that can be assessed are hardware or bony compression of nerves. In this instance, we see a orthopedic screw from a humerus impacting the radial nerve. So these are all things that can be assessed at the bedside in near real time and helping guide that urgent treatment. With respect to our more non-urgent lesions, basic things like protecting the limb, involving the chronic pain team or acute pain team early in managing neuropathic pain are essential items. If it's simply a sensory injury, the outcomes are exceedingly good, and reassurance is really important for the patients at this time. There should be a review in 2 to 4 weeks to look for improvement and consideration of neurophysiology studies. So the neurophysiology studies that we typically look to are nerve conduction studies. These are to assess electrical conduction over a nerve and identify the location of the blockade or slowing of the nerve. And they're really limited in time, and the most benefit occurs after 2 to 4 weeks when we've had our Wallerian degeneration, and we can truly get an impact of outcomes, and also they provide good prognostic information for axonal regeneration. EMG is another modality. This assesses the electrical muscle within the activity. Again, not terribly useful until about 2 to 4 weeks, but it can give some information about pre-existing pathology. Key pieces here are to have a familiar neurologist. To be fair to our neurology colleagues, neurology is a broad topic, and their intimate knowledge of what goes on with regional anesthesia and where interventions are placed, as well as surgical interventions, is a big topic. So it's very important to have a familiar neurologist that you can work with on your team. And again, don't forget to include the acute and chronic pain, as well as physical therapy and occupational therapy teams. So that's a very rapid review of management for our patients with peripheral nerve injuries. Summary, the big things and big take-homes are that peripheral nerve injuries from regional anesthesia are exceedingly rare and typically with very good prognosis, but they need to be identified. It's important to recognize the varying etiologies of postoperative peripheral nerve injury, as they're always multifactorial. Reliable patient follow-up and assessment is essential, whether this is in person, by telephone, or some other form of direct communication. And finally, it's essential to have a consistent plan and team in place to both assess and manage these patients as best we can. So thank you very much for your time.
So Riva or Ashtem, can you share your screen?
Yeah, just give me a second. Seems to have disappeared.
Okay, so myself, Etienne Niazi from Toronto University, and from Riva Rablo from the University of Ottawa. We're going to be presenting our next topic, which is teaching regional anesthesias to the next generation. So to avoid nerve injuries and to avoid rebound pain or failed blocks, it's best to teach our new generation of new trainees how to do regional anesthesia properly. So I'd like to thank ladies and gentlemen for joining us on the second World Day of Regional Anesthesia Pain Medicine. It's actually great to see so many people from all over the world. Special shout out to people from Pakistan who are joining, and as I'm from Pakistan myself. And we'd like to thank the CAS for organizing this and Joanna for moderating this session. So as I said, we'd like to talk to you today about how to teach ultrasound-guided regional anesthesia to the next generation, but this is not limited to next generations, but to older generations as well. Dr. Rao no longer has nothing to declare. I, on the other hand, have a Canadian Anesthesia Research Foundation Education Simulation Research Grant, which is supporting my current work. I do tend to forget, but I'm also an associate editor of the Regional Anesthesia Pain Medicine Journal as well. So today, our objectives of our talk are basically will be to discuss how to break down ultrasound-guided regional anesthesia into easy steps, which can be taught separately. We'll talk about how some steps can be taught didactically, but others require hands-on practice. We'll also discuss using technology to teach ultrasound-guided regional anesthesia and how this knowledge and these skills can be evaluated to determine proficiency. The use of ultrasound, as you all know, has revolutionized regional anesthesia, but it has also introduced new knowledge and new skill sets which need to be learned prior to being proficient in this skill. Rightfully so, the new knowledge and skills introduced by ultrasound were discussed by the ESRA and the ASRA Regional Anesthesia and Pain Therapy Joint Committee, which provided guidelines on how to best teach regional anesthesia. These guidelines provided us with an important message, This message was that ultrasound-guided regional anesthesia requires both a didactic as well as a hands-on learning component to become proficient in this skill. Furthermore, this committee divided ultrasound-guided regional anesthesia into 4 components, and these were image generation, image optimization, image interpretation, and needle insertion and injection. Looking at how best to teach ultrasound-guided regional anesthesia, he found that ultrasound image generation, image optimization can be taught by didactic teaching. This could be in the form of a lecture, video, or a PowerPoint presentation. On the other hand, next slide, ultrasound image interpretation and needling skills require hands-on practice. Next slide. Image generation or knowledge, next slide, includes learning about ultrasound machine and how you can use the machine to provide you with an excellent image. This is understanding, first of all, how to switch the machine on, which buttons to use, and then using gain button to reduce or increase the brightness, using depth to get the target in view, and using Doppler function to identify vessels. It is also required that you should be able to save or acquire an image by using the freeze and the save freeze button function on the machine. The next thing is image optimization. How can you do that? First of all, the most important thing is to select the right probe. There are a number of probes on a machine. The most common probes that are used for regional anesthesia are the linear high frequency probe or the curvilinear low frequency probe. The high frequency probe are best for superficial structures as they have the best resolution up to about 4 centimeters. Low frequency probes are good for deeper structures as their resolution is best below 4 centimeters. The next thing is transducer movements. These are specific movements that you can use with your transducer to optimize your image. And these are pressure, alignment or sliding, rotating and tilting. For pressure is great for deep blocks. You have to rotate, slide and tilt your probe to get the nerve in its best cross-section view, which optimizes the image. An example of this is when we're doing the popliteal sciatic nerve block at the popliteal fossa, where due to the nerve running deep in the leg, tilting the probe cephalad can actually improve the image drastically, as we all see. Next slide. Image interpretation requires hands-on practice. This is where you have to scan your patients and colleagues and have a knowledge of anatomy. Constant scanning helps you develop a pattern recognition, which allows you to distinguish between muscle, vessel, bone, and nerve, and is important to scan dynamically along the path of the nerve to determine its course and best place to block. Next slide. One of the more difficult skills to learn is needle visualization, as it requires hand-eye coordination. This is aligning the needle with the probe or the beam of the ultrasound as it emerges from the probe. However, it is considered to be a core competency of learning ultrasound-guided regional anesthesia. Basically, without this skill, you're not going to be able to become proficient in ultrasound-guided regional anesthesia. This skill again requires hands-on practice, but can be taught on simulation models, which could be simple low-fidelity gel or meat models, as long as it contains a target and allows ultrasound penetrance. Next slide. During our study on how to best teach ultrasound-guided regional anesthesia, we came across many papers by our surgical colleagues, which had similar learning methods for teaching laparoscopic skills. There are many parallels to laparoscopic surgery. Also requires hands-eye coordination. It requires depth perception and a knowledge of anatomy. To develop the ultrasound-guided regional anesthesia curriculum, we also adopted some of what our surgical colleagues were doing, which included breaking the procedure into easy steps with practicing each step with supervision and feedback, allowing deliberate practice on simulation models, and once each step is mastered, then performing the procedure as a whole. So next slide. So what is the difference between deliberate practice and just practice? Deliberate practice plays a strong role in learning any skill because it has a component of feedback which is provided to you after performance of each skill set or procedure. So the key component So the two studies which kind of do give you a good idea of what feedback actually proves is that the Oliver DeFellow et al. Did a study in which they taught two skills of ultrasound guided regional anesthesia. One was needle alignment and the other was target acquisition. They provided no feedback to the students, and it took the students 37 attempts to get the first skill in hand and 109 attempts to get the second one. In contrast, Seitz et al. Showed that teaching target acquisition with proper feedback after each attempt reduced the error rate from 31 to 1 in only 6 attempts. So these students attained proficiency much faster with feedback than those in the previous study where no feedback was provided. I'm going to hand it over now to my friend and colleague, Dr. Ram Logan, to continue on.
Thank you, Dr. Niazi. So why should we use technology for teaching? Using technology in teaching can address a number of concerns, such as the lack of adequate clinical volumes with work hour restrictions, limited faculty time for teaching due to OR time pressures, unrealistic part task trainers, the increasing number of blocks due to the use of ultrasound. There are also ethical considerations. The French High Authority of Health says that we should not be performing procedures for the first time on a patient. Computer technology or technology can also help in deliberate practice because you can perform an infinite number of repetitions. These are the 4 technologies I'll be talking about today: computer-based technology, needle guidance, artificial intelligence, and immersive virtual reality. This is an online simulation model for learning spinal ultrasound. And we evaluated its role in learning and found that it significantly improved the knowledge of spine anatomy and sonoanatomy. The users could use a virtual ultrasound probe and see the neural elements under this ultrasound. And what are the advantages of these electronic online modules? They're easily accessible. They provide for just-in-time learning and distributed learning, so there's no geographical borders, and no additional equipment is required. Learners find it engaging through the incorporation of multimedia, such as simulated ultrasound images, 3D images, and animations. McLeod and his group evaluated the use of needles with tip tracking technology. The tip is displayed as a green circle on the ultrasound screen. If it's red, it means that the needle tip is not aligned with the path of the ultrasound beam. And the blue circle demonstrates how far away the needle tip is from the beam. This technology has been found to improve needle tip tracking in novices performing a sciatic nerve block. Artificial intelligence systems are available, and some have been built into the machines, whereas others require an additional piece of equipment. And these artificial intelligence systems have been trained on hundreds of thousands of ultrasound images from hundreds of subjects. They employ deep learning algorithm softwares which identify specific patterns and features that are indicative of nerves and other structures. This is usually represented by a color overlay, as seen in this pop fossa sonogram. Bonas and colleagues have evaluated one of these AI systems and found that novices, as opposed to experts, are the ones who perceive the greatest benefit. Novices felt it improved their scanning technique and sonoanatomy. The authors do caution that there can be errors in highlighting, which will lead to misinterpretation. Similarly, the highlighting can distract focus away from critical structures. So these systems are not a decision-making system. They just provide us with extra information. Virtual reality is used to describe a three-dimensional computer-generated environment, which can be explored and interacted with. My colleague Yuki Gu and I created this VR environment to learn and practice fascia iliaca blocks. It has similar benefits as online modules, but also allows for pre-training before practicing these blocks on patients, and it allows for deliberate practice of needling. We asked ChatGPT to make an image of ultrasound-guided regional anesthesia, and this is what it came up. So somehow it found a fetus in the leg. So I don't think the machines will be taking over anytime soon. So how do you assess trainees for competence? There are a number of workplace-based assessment tools. The most familiar one is Canadian by Chung and colleagues, and the other is by Alwyn Chuan out of Australia. They both combine the use of a checklist and a global rating scale, as together they produce a more holistic evaluation. Checklists allow assessment of individual components of a procedural task. They usually employ a dichotomous outcome scoring, such as performed or not performed, whereas a global rating scale is more suited to non-technical skills such as communication and are graded on a Likert scale. Both of these assessment tools have been found to demonstrate construct validity, which means they can differentiate between novices and experts, as well as external validity, meaning that the scores are reproducible between different assessors. These assessment tools allow the evaluator to provide specific feedback on the trainee's deficiencies, which provides them with the information necessary to perform deliberate practice. Here are two assessment tools that use purely objective data. On the left, we see a heat map of an eye tracking device. It identifies gaze fixations and eye movements to determine a user's focus of attention. Compared to novices, experts tend to fixate their gaze on the target for a longer period of time before making a critical movement, whereas the novice's gaze tend to be scattered throughout the sonogram. It's been proposed that eye tracking can be used to assess acquisition of expertise or competence. The other assessment tool is the Imperial College Surgical Assessment Device, or ICSAD, which uses hand motion analysis to measure various dexterity parameters, such as procedural time, path length, and the number of movements. The sensors are applied to the dorsum of the hands underneath the sterile gloves and connected to a laptop running the analysis software. And this software has been found to demonstrate construct validity for performing a supraclavicular block.
So in summary, we'd like to say that the ultrasound-guided regional anesthesia can be divided into four main, or can be broken down into four main portions: general image generation or knowledge, image acquisition, sonoanatomy, and needling skills. You have to be proficient in all four of these skills and knowledge sets to be able to be competent in regional anesthesia.
And in addition to didactics, we can use computers and online modules to improve image generation and image acquisition. We can use artificial intelligence, computers, and online modules to improve image acquisition and sonoanatomy. And needling skills can be practiced with simulation, virtual reality, and needle guidance systems. In assessing for competency, we need to use objective assessment tools, which can provide specific feedback so that trainees can perform deliberate practice.
Thank you.
Welcome to the last lecture in our webinar. The topic of our talk is Emerging Techniques in Regional Anesthesia and Acute Pain Management.
My name is Ryan Indersby. I'm a clinical assistant professor at the University of Calgary.
And I'm Vivian Ip. I'm a clinical professor also at the University of Calgary.
These are my disclosures, which aren't relevant to this talk.
And here are my disclosures. I'm the chair of the Regional Anesthesia Section at CAS, the chair of ESRA Pain Medicine Newsletter Committee. I'm the editor of RAPM. I'm also on the editorial board at CJA. Here are the learning objectives for today's talk, and we are primarily going to talk about cryoneurolysis and peripheral nerve stimulation as forms of neuromodulation in acute pain.
You may wonder how cryoneurolysis works. Well, we treat nerves with low temperatures, usually minus 20 to minus 80 degrees Celsius. This then results in degeneration of the axon and myelin sheath, which temporarily blocks nerve conduction. The axon then regenerates slowly at a rate of about 1 to 2 millimeters per day. It then reinnervates the structures it formerly innervated, and nerve conduction is restored. You may wonder what cryoneurolysis devices look like. There are a number of cryoneurolysis devices throughout the world. Generally, they fall into two different categories: handheld devices, which you can see on the left, and console devices, which you can see on the right. You may wonder how the device actually works. Well, most modern cryoprobes feature a tube within a tube design. They convey high pressure gas, usually carbon dioxide or nitrous oxide, through the outer tube down to a narrow annulus, which then empties into a low pressure closed end. This then causes a cooling effect based on the Joule-Thomson effect, resulting in ice ball formation from the patient's water in their own tissues. The gas is then vented through the inner tube and back out the cryoneurolysis device. There are a number of cryoneurolysis contraindications. Those include some uncommon things and some more common things. The very uncommon things are things like cryoglobulinemia, paroxysmal cold hemoglobinuria, cold urticaria. More common things are things like Raynaud's disease. There's also the contraindications for a lot of our percutaneous techniques, such as open or infected wounds at or near the treatment site, patient refusal, and being on anticoagulant medications or having a bleeding diathesis for some particular procedures. You may wonder what the cryoneurolysis complications are. Well, they're similar to a lot of our percutaneous techniques, such as ecchymosis, edema, erythema, localized pain or tenderness, localized dysesthesia. You can also get other things like frostbite to the skin, which can cause hyper or hypopigmentation, skin dimpling, and if used in very close proximity to motor nerves, you can get loss of motor function.
How about the use of neuromodulation with nerve stimulation? Back in 2018, the US Food and Drug Administration approved 2 neurostimulation devices, which are percutaneously placed leads to be used in acute pain. These leads have traditionally been used to treat chronic pain. Actually, there is a Canadian Neuromodulation Society, and the president is Dr. Anuj Bhatia from Toronto. They define neuromodulation as the alteration of the nerve activity through a targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body for restoring function or relieving symptoms that have a neurological basis. In other words, local anesthetic used in regional anesthesia can also be seen as a form of neuromodulation. So, how does it work? There have been several proposed mechanisms of action. One is the gate control theory, where the perception of pain can be reduced by stimulating the competing non-painful stimulation through large fiber neurons to shut the pain gates. Another theory is that peripheral nerve stimulation changes the endogenous neurotransmitters and affect the plasticity of the NMDA pathways, or that the repetitive stimulation reduces the excitation of the pain fibers. Others think that peripheral nerve stimulation modulates and reduces the autonomic and inflammatory cytokines. Currently, there are 2 systems that can be used for peripheral nerve stimulation to treat acute pain. The one on the left is commonly used in chronic pain, and it is FDA approved for use in acute pain as well. A very fine lead is inserted through an introducer sleeve. It is then placed about 1/2 to 3 centimeters away from the target nerve percutaneously, with either X-ray or ultrasound guidance. The lead is then attached to an external stimulator, usually for several days or weeks. The one on the right is the hybrid system, using both the local anesthetic and stimulation. This is not FDA or Health Canada approved yet. But this insertion is simple, because it is no different than inserting a nerve block catheter, usually under ultrasound guidance, and the stimulating catheter tip is placed perineurally. The only difference is that the catheter tip has stimulating capability when attached to a nerve stimulator, usually for a short period of time.
You might wonder what the evidence for cryo is. We'll look at cryoneurolysis used for acute pain. It's largely been used for total knee arthroplasty, but there's been other reports of its use for hip fracture, shoulder surgery, limb amputations, mastectomy, as well as rib fractures and burns. Probably the largest study of cryoneurolysis used for total knee arthroplasty is a study done by Urban in 2021. It was a retrospective study of 267 patients. They used ultrasound to target the anterior femoral cutaneous nerve and the infrapatellar branch of the saphenous nerve, and then performed cryoneurolysis. They found that in their study, the group that they treated with cryoneurolysis had required fewer opiates postoperatively up to 6 weeks after their surgery. The cryoneurolysis group also had lower pain scores and a shorter length of stay. We also have used cryoneurolysis to treat a hip fracture that was deemed non-operative. We have this case report pending publication in the Canadian Journal of Anesthesia. She was a 97-year-old female patient with end-stage respiratory disease who sustained a subcapital hip fracture. We then administered a spinal anesthetic for her hip hemiarthroplasty. However, she suffered significant respiratory compromise, and that resulted in the abortion of the surgical procedure. We then discussed performing a pericapsular nerve group block with the patient, the family, as well as the surgeon and the several of our anesthetic colleagues. This worked remarkably well for her, and as a result, we then had a discussion with them regarding performing a pericapsular nerve group cryoneurolysis, and they agreed. So we performed this, and it resulted in significant improvement in the patient's pain on movement. She no longer required any opiate medication for the remainder of her stay, and her pain was just managed with acetaminophen only. She was able to get up to standing with the help of her physiotherapy and nursing staff, and she continued to do well and was discharged to an assisted living facility 7 days later. Cryoneurolysis has also been used for limb amputation. In this study by Ilfeld, it was a pilot study where they had 7 patients undergoing limb amputation, and they randomized them to femoral and sciatic nerve cryoneurolysis, or sham. They found that the patients who underwent cryoneurolysis reported lower pain scores at all time points between day 1 and 21 following their amputation. They also had decreased opiate consumption at all time points, again between day 1 and 21 following their amputation. Ilfeld also looked at cryoneurolysis for rib fractures. In this study of 20 adult patients, they randomized patients either to active cryoneurolysis or sham. The primary endpoint was maximum inspired volume the day after the procedure. They found a statistically significant difference between the cryoneurolysis and the sham in the maximum inspired volume, favoring the cryoneurolysis group. The average pain scores were generally lower in the cryoneurolysis group throughout the first month. They also found that the total cumulative oxycodone equivalents were also lower. Finally, and probably most interestingly, was this study done by, again, Ilfeld and colleagues, looking at cryoneurolysis for mastectomy. They had 60 subjects undergoing mastectomy who they randomized either to cryoneurolysis or sham of the T2 to T6 intercostal nerves. All the patients also got paravertebral blocks, which was their standard of care. Their primary outcome was pain on postoperative day 2, and they found a statistically significant pain score reduction on postoperative day 2, favoring the cryoneurolysis group. There was also evidence for superior analgesia up to month 12 in the cryoneurolysis group. And during the first 3 weeks, the cryoneurolysis group lowered opiate use by about 98%. And probably the most interesting finding of their study was at the 1-year follow-up, the chronic pain only developed in 3% of cryoneurolysis group versus 17% in the sham-treated subjects.
How about evidence for using nerve stimulation as a neuromodulation technique? There are 2 randomized controlled trials looking at using the chronic pain system for nerve stimulation in acute pain. This is a multi-centered randomized controlled trial with a sample size of 66 patients who had nerve stimulation versus sham for 14 days to the sciatic nerve for foot and ankle surgery, femoral nerve for anterior cruciate ligament reconstruction, and brachial plexus for rotator cuff repair, and they found a statistically significant reduction in pain score and opioid consumption for the first 7 days out of the 14 days of stimulation. And similar to their previous study, the same group conducted this randomized controlled trial with 40 patients, looking at stimulating the brachial plexus and the sciatic nerve versus sham for 14 days. Again, they found a difference of opioid consumption and pain score for the first 7 days out of the 14 days of stimulation. For the hybrid technique, yes, it is off-label, and there are only case reports and case series, but these describe challenging cases, like patients on opioid and who tend to be excluded in randomized controlled trials. This case report described the effectiveness in reducing pain score, opioid consumption, and facilitated mobilization in refractory postoperative pain setting following hip arthroplasty. Nerve stimulation using the hybrid technique can also be used in challenging pain patients who are unresponsive or refractory to local anesthetic infusion alone following below-knee amputation, as described in this case report. The patient had complex phantom pain, and peripheral nerve stimulation was used as a last resort, and that significantly reduces the pain in both the amputation stump and the phantom toes. This case series described 6 other challenging cases after BKA or below-knee amputation. There's still many unknowns in this field, but it is pretty clear that for both cryoneurolysis and peripheral nerve stimulation, selecting the suitable patients seemed to be the key to success. I hope our presentation gives you a taste of some innovative treatment modalities emerging in acute pain arena. And these treatment regimens do require careful patient selection, and some of these are off-label, so more evidence is warranted, but watch this space. Thank you.
Thank you again to our presenters today. You gave excellent and informative presentations, and it was such a joy to hear all of you speak. We're going to open it up to ask questions. And before we wrap up for the day, I just want to put a shout out to the upcoming CAS education sessions and events. And don't forget to join us for the CAS in St. John's, Newfoundland, Canada in June for the CAS 2025. So I'll just open it up for questions now.
I think a lot of questions, Joanna, are on rebound pain, so I can maybe just get answering some of these questions. I was actually getting ready to go out on this sunny day, but looks like all the sun is gone now. And if I go outside now, I might get cryoneurolysis. The temperature has dropped down to that level now. So getting started on Elsa is talking about definition of rebound pain. And as I said, that's a big matter of debate, how you define, because the problem is the variability in blocks on the type of blocks and what adjuvant we use. So I will I will leave that to for the time to decide, like what eventually people decide, because the blocks, each blocks last different duration. But I think we all agree in the concept that um, that like it's just going from controlled pain to uncontrolled pain whenever the block wears off. What time that happens is a matter of debate. Um, Dr. Narendra Singh, the king of NMAs, is saying he's getting an NMA out in anesthesia soon, comparing perineural versus IV dexamethasone NMA. So we're looking forward to his results. Currently, I found one study only, which I presented. Um, and then we have a question by Melanie asking if there is, you guys know that there are other speakers as well. All the questions did not have to be directed to me, um, um, but I'm happy to answer them. Uh, I was actually answered all those questions in the chat box, not realizing that only panelists can hear the or read these answers. So but we do have 5-10 minutes, so I think we can get over these questions. Uh, Melanie's asking whether there's a multi-center study going. I am not aware of this, but sometimes it's hard to find on clinical trial registry, and some of these studies which are on registry actually and never come to completion as well. So if you have any, just put it in chat box if you are a part of one, so you can share it with us. Dr. Food asks about um, combining, it's a great question, about combining dexamethasone with Presidex or dexmetomidine for rebound pain. I did not see any studies combining the two. Um, on a fairly extensive literature search I did. But to my knowledge, like both of them provide similar duration of analgesia. In fact, dexamethasone provides a slightly longer duration of analgesia. Whether their effect would be supra-additive, I'm not sure. So it's hard to comment on that. But I do feel that the more drugs we start mixing, the chances of us causing errors, drug errors, goes higher and higher. And dexamethasone is probably fairly the one which has the highest amount of evidence for it. So just stick to that. And Dr. Food also asked about PO hydromorph, PO dexamethasone, which is another great question, because from what I understand, the bioavailability of PO dexamethasone is same as that of, or similar to that of IV. But in most cases, we do have an IV available in hospital. But in some cases, if you can get an IV or the patient is in outside the hospital, that might be an alternative. But great question. Alan Chow says, love the honeymoon analogy. I agree with that. I love it as well. People find they can relate to it, especially married people. And we have a question about and combination again, which we've already answered. I can't see any more questions.
I think there is another question for Dr. Endersby as well, and also people can feel free to unmute and ask questions verbally as well.
Maybe put the hand up feature, see if we can let them go in the sequence. But I will shut my mouth and let other speakers answer the question.
I will also say there is a question in the Q&A as well about cryoanalgesia. So perhaps Dr. Endersby could answer that one and the last one in the chat box.
Sure. I guess the question is, are there any concerns for pain reoccurrence after cryo? So if you're doing it for acute pain indications, oftentimes the duration of effect of the cryoneurolysis sometimes matches the duration of pain that you're going to expect with their acute pain. And so once the cryo wears off, they don't necessarily have that much acute pain. This is a different story if you're doing it for chronic pain indications and what those chronic pain indications are. And it can be very variable depending on the patients. I mean, I've had some patients where we've done cryo for say like a brachial plexus injury since birth. And I did that probably a year or two ago, and the pain hasn't really come back to a significant degree. And then, you know, I've done cryo for patients with osteoarthritis, and I've had their pain reoccur after several months. So it can be very variable.
I'd like to ask, oh, sorry.
Go ahead.
So I was just gonna add, the field of both cryoneurolysis and peripheral nerve stim for neuromodulation is still fairly new, and there is a lot of unknown. And of course, there, you know, more evidence needs to be out there for us to be more certain of what we are, you know, what the parameters are. And I think Dr. Ramlogan asked, you know, how many, like what's the length of the neurolysis treatment need to be on the nerve? Well, again, it depends, like how many ice balls do you know, how many cycles do you need? Like, is it 3, is it 5? We don't really know. And also patient's response is very different. We find that patient selection is very important, even for nerve stimulation, say for below-knee amputation. It is, you know, so far it is off-label because I tend to use the hybrid technique. It is off-label. But then I'm seeing, you know, we're looking at cases and we're seeing patients, you know, I don't even need to tell my acute pain nurse what I did like the day before. They already come to me and say, what did you do to Mr. X or Mr. Y or Mrs. Y that, you know, she is like not having any phantom pain anymore, or her pain is much better. So even without me telling them, I've actually like stimmed them. But then for other patients, it you know, it doesn't seem to be that effective. Anything to add, Dr. Endersby?
No, I think you summarized it quite well.
So I think that I don't see any other questions in the chat box, unless I have missed some. But I just want to highlight that you can scan this QR code as well to get the World Day of Regional Anesthesia app. And there's a couple surveys there, which are super fun to fill out as well. Oh, it looks like there's one more question in Q&A. I think, Dr. Endersby, that one's for you. If you
Yeah, so there can be a problem if you do it too close to skin. But there are a lot of things that you can do to kind of mitigate that. Probably the most effective thing to mitigate that is use a sheath, like an introducer sheath. So we often use like a 16 gauge IV cannula to insulate the skin. And we haven't really had any problems with frostbite to the skin. I'm part of a cryo kind of group of people that on WhatsApp, and they all similarly like use these introducer sheaths to try to prevent frostbite. And really, it's not a problem that I've heard of if you do that.
Alrighty, so I think that we have come to the end of our session. I just want to thank again the presenters for all their wonderful presentations and hard work and expertise on these topics. We look forward to seeing you at CAS 2025 in St. John's, Newfoundland in June. And thanks everyone. Have a wonderful day.